Thank you, Trish. Good morning, everybody. As you said, my name's Nick Fahy. I have been a policymaker for most of my career, mostly for the European Union, partly for the British government, and I got very interested in these niche questions of social science in personalised medicine. And so I got lured into academia by that lady over there. And so now I work in Trish's group, Indeed. I just want to preface by saying I'm very grateful to St Anne's for hosting the Centre for Personalised Medicine for, together with our colleagues, putting on this event. It's been a pleasure to collaborate. We're very proud from the partnerships theme of the Biomedical Research Centre to be able to contribute to exactly this kind of interdisciplinary discussion, and it's a pleasure to see so many different colleagues represented here. And I would want to thank Alex Rushforth and the colleagues from the Centre for Personalised Medicine in particular for all their work. Alex has been, I'm involved in another event at the moment which is taking up an enormous amount of time and effort to organise, and this one just all happened because Alex did it very well, so I'm very grateful. I want to talk about three things. I want to talk about some of these wider policy and system challenges. I want to talk about some of the infrastructure and the systems change that personalised medicine involves. I want to talk about some particular challenges for the UK, although I know that there are interests that go much wider than that. And then I want to talk about some fundamental systems challenges to the whole innovation system, the model of drug development and the values on which we finance and base our health systems that are implicit in this. And I want to pick up on the political economy point that was made at the end of the previous session. And trigger warning, I am going to mention Brexit on the way through. I'm sorry about that. So let's start with infrastructure, because one of the things that we look at in our research group is about processes of complex change. And processes of complex change are pretty much any processes of change within a health and care system. Because I used to work in a ministry, and ministries are very well structured and orderly places. There are people at the top, and each layer at the top tells the layer down what it wants to do, and there are processes and structures of advice, but it is a classic bureaucratic organisation. And it mostly works quite well. Health systems we also like to think that health systems are classic bureaucratic organisations, and we have executives at the top of them, and they tell the people within the health system how to work, and everything happens that way, doesn't it? It really doesn't. And I'm sure the ironic laughter is from anyone who has ever tried to bring about change in a health system. And one of the areas of change that we've been trying collectively to bring about within health and care systems for at least the last 20 years has been about the potential of information and communication technology. From electronic health records, information and communication systems, being able to move data from one place to another. And even, we did some work recently, Trish and I and some colleagues did some work with the permanent secretary of the Department of Health of this country. And one of the case studies that we were looking at was the e-prescription setup. And I think, Trish, they said they've been working on that for about 10 years at this point when we were talking to them, 15 even. And they're still not fully in place. And now let's think about what this means. You have a defined list of products in a formulary. You know what all your drugs are. You know who all your pharmacies are. You have an established system where you have a data flow in the form of prescriptions that goes from your doctor, perhaps via your patient carrying a bit of paper, to a pharmacy. You have an established wholesale system, itself already largely digitalized. This should be easy, right? If you can't do this, how are you going to do electronic medical records? And as I say, 10, 15 years, and it's still not fully implemented. And it's not fully implemented because this isn't a Weberian bureaucracy. This isn't a top-down command and control system. This is a system where each individual set of actors is acting in their own ways, for their own reasons. People are acting on their own initiatives. You have different professional obligations, organisational obligations. The whole system is under enormous pressure. It is not an easy environment for change. Why is this relevant for personalised medicine? At the heart of personalised medicine, one of the core issues is data. And we quite often focus on data in terms of the values, the acceptability, the consent, are people happy to share their data? What I want to underline is just the sheer practical difficulty, how far our health systems are from being able to share and communicate and pool data in the ways that we need to make personalised medicine a practical reality, something that you can really implement across the system. Now, I think the examples of looking at electronic health records are instructive, and I was recently involved with a World Health Organization conference in Copenhagen, which was a symposium on the digitalization of European health systems. And it reminded me slightly of what Gandhi said when he was asked what he thought about Western civilization. I don't know if anybody knows this quote. He was asked what he thought about Western civilization, and his response was, "It would be a good idea." Digitalization of European health systems, yes, it would be a good idea. Now, one of the most advanced presentations there was the Danish e-health portal. And the Danes, I think, have gone about this in a particularly clever way, although they didn't necessarily intend to do this right from the start. You might look at the Danish e-health portal, which provides access to a huge amount of personal data, which is used by patients, by clinicians, by GPs, by hospital doctors. There's an ability to identify records across different providers, to track your flow as a patient through the care system, to share clinically relevant data. You might think, my gosh, they've got a wonderful system for data sharing. Actually, they don't. They've got several hundred different systems that they have, after decades of work, managed to begin to make links together between. So what have you seen? You've seen a whole set of different data systems emerging, and slowly and with an enormous amount of effort, both technological and cultural, in terms of getting change within the system and getting public acceptance, you've managed to get a system that is willing to build bridges and make linkages between these different parts of a data system. I always used to say at European level, there is a right size for change, and I did used to say this beforehand, the right size is roughly Denmark. Because if you are, say, Luxembourg, you're just too flipping small. It's too, you haven't got the capacity, you haven't got the critical mass. But if you are the UK or Germany, you're too big. It's very hard to make those interpersonal relationships. Any system that you design, you try and design for just too many different use cases, and it becomes incredibly hard to bring about change. Purely pragmatically looking at which systems across Europe have made the most advances, around about Denmark. And so there's a lesson there for structure of health services, I think. Why are we trying to still run things at that centralised level? But I would like to just underline that point about complex change and the difficulties of it in relation to personalised medicine, about the infrastructure that we need to have in place and how difficult that's going to be. That leads me, to the Brexit point. Now, we don't know what form Brexit is going to take. I can't quite believe, and of course it could have changed by now since I last looked, but we are on the 21st of March and we still don't know what it is. But let's assume for the purposes of this talk that there will be some form of Brexit, and we will be faced as a country with becoming an independent jurisdiction for pharmaceuticals licensing and medicines development outside the two major global jurisdictions of the European Union and the United States. What do? We might just accept that we are going to take between 6 months and 2 years longer than anywhere else, than either of those jurisdictions to get access to medicines. Totally valid. Not sure what the public's going to think about that, but we could do that. We could try and just build ourselves back into one or the other of those two jurisdictions, or we could try and identify a specific niche for the UK, which is so special and so distinctive that it means that actually stuff happens here, research happens here, and products are brought on the market here quicker than elsewhere because we're just that much better. And personalised medicine is one of the areas that is identified for this. I've heard a lot of talk about this in policy circles. We have an integrated NHS, we have a wonderful research environment, we can be the world leaders in personalised medicine. Now let's leave aside for a second that the impact of Brexit on both our life sciences sector and the NHS is going to be negative, no matter what the form of Brexit is, and the harder the Brexit, the more negative that impact is going to be. If you want details on that, by the way, look up impact of Brexit in Lancet, where I and a number of colleagues published a remarkably depressing pair of papers that I'm not going to talk any more about. Let's leave that aside for a second. Think about the challenge that this represents for the NHS. Think about the challenge of infrastructure, and how many people here remember the whole spine, the integrated electronic patient record within the UK? Does anybody remember that as being an overall success so far? So I would just invite you to think there is a possibility there. I don't think it's completely fanciful. I know a lot of work is being done to develop infrastructure around this, and Tom is going to talk more about that in the next presentation. But I just want to underline the sheer practical challenges that would be involved, and the sheer amount of reform and investment that would be required within an NHS where at the moment our current challenges are overcoming the use of pages and fax machines, in order to, pages and fax machines have their role, but in order to develop the kind of integrated research, development and licensing environment that we would need to have to be so much better than the European Union and the United States that companies and researchers would want to come here. And then this leads me on to my third point, which is about the challenges that personalised medicine places to two crucial aspects of the system as it currently stands. And this brings me on to political economy, which is a phrase I wasn't going to use until the end of the last session, but I'm going to now. So there are two aspects of political economy I want to talk about. The first is drug development, and the second is the financing of health systems. Drug development. The basic model of drug development at the moment is, as Mariana Mazzucato, amongst others, has pointed out, that we invest a lot of public money at the start of the process in fundamental research, carried out, among other things, by colleagues here. We then spin that research out into the private sector as quickly as we can, and we rely on the private sector to develop actual marketable products out of that, which it does, but at enormous cost. And then we stand at the end of the process with a checkbook, deciding whether or not we're going to pay for it. And the enormous costs of the development process are acceptable because we spread them out over as many patients as we possibly can. The problem that personalised medicine represents for this process is that the whole premise of personalised medicine is that we are not spreading these costs out over as many patients as we possibly can. And yet, how many people here think that development of personalised medicine therapies is going to be cheaper than development of existing therapies? Cheaper or more expensive? I see one optimist saying cheaper. So if we're going to have even more specialised therapies and development costs targeted on an even smaller number of patients, how does that work actually? How are we going to, there is a fundamental political economy question about how we do that. There are a number of possible answers which we don't have time to go into now. But this is not, it cannot be business as usual for our existing innovation system. We have to rethink something about that structure of development and the different risks and rewards that we have built into it at the moment. And globally, by the way, this is going to be a particular challenge for Europe and the United Kingdom. The total of all the wonderful publicly funded healthcare markets of Europe is around about 2/3 of the total size of the healthcare market in the United States. So if you are a medicine developer, if you're a drug company, which market do you target? Well, you target the United States. But the incentives and rewards in the United States market are fundamentally different to the needs of the more publicly funded European markets. And I don't think that we've really thought through what that means in terms of the innovation system and how our innovation system should be different. And I want to conclude with this point about the point that came up at the end of the last session about risk stratification and pooling and values. So we're very attached to the NHS in this country, but one of the points that I always underline whenever I stand up and talk about this is that our values of universal access to high quality healthcare financed on the basis of solidarity and available to everyone on the basis of need, those are values shared by the health systems of Europe as a whole. These are not NHS values. NHS systems exist in other European countries, and even in the other European countries which are funded more on the Bismarckian social insurance model, this is still publicly financed, and it is still financed on the basis of solidarity. But we quite often justify this on the basis of risk pooling. Why do we put in our money to this? Well, we don't know what's going to happen to us, and so we all need to spread the cost, like any other kind of insurance. But when we actually do know what's going to happen to us, when we acquire more information, when it becomes easier to predict our long-term health, that argument of risk stratification does indeed begin to get problematic, because now we're not paying for risk, we're paying for people with wildly different needs. But colleagues, the argument I would want to make is that we've never said these health systems are health systems financed on the basis of risk pooling. We've said that they are financed on the basis of solidarity. Solidarity between us as people and as communities and as part of our commitment to a set of values. And I think that when we have these discussions about personalised medicine, we need to start from that place. And we need to be framing these discussions not about, we might want to stratify services, we might want to stratify our provision, but our financing and the whole way in which we discuss financing, I would argue we don't root in technical discussions about evidence and risk pooling. We have to start from narratives of values and solidarity across our societies. And that is the final message that I wanted to end on. Thank you very much.